in terms of future directions when it comes to RCC, what clinical trials or research areas are you most excited about?
You looking at me again?
Yes.
I mean, I can't tell. Sorry. I think for this GU ASCO, I think the most interesting new data is the ARCUS HIF inhibitor data that'll be presented on Saturday. The abstract's already out. I mean, it's very similar in design to belzutifan. So it's always good, I think, to have more than one drug with the same mechanism of action, to test in a particular disease. This drug, based on the abstract, looks active. I mean, we'll have to see the data. The unconfirmed response rate was north of 30%, so that's encouraging. And to me, if it moves into the clinic, one of the things I would like to see is us studying it up front in selected patients as a single agent, which is not currently the Merck strategy with belzutifan. They're moving it up front, but in combinations, which makes sense, at some level. But so having more than one drug to play with will hopefully improve outcomes for our patients.
Yeah, I have my eyes on the adjuvant trials because we are waiting now for combination strategy in adjuvant. So we'll have in the coming years the belzutifan plus pembro. Is there a rationale to give that drug earlier? I hope that we can have biomarker-guided strategy in adjuvant, as we discussed. There are efforts to develop personalized vaccine strategy, and we recently had a very nice publication from Boston with the team of Tony Schwery, but also David Brown, who did this personalized vaccine strategy, published in Nature, only 9 patients, but immune response, and no patient relapsing. And so this is taken to another level with the V940. This is, once again, a personalized vaccine strategy. So you use the specimen of the tumorectomy, the nephrectomy or the tumorectomy, to generate a personalized vaccine on top of pembrolizumab. This is a phase 2 for RCC, but also already demonstrated the proof of concept in melanoma. So that's another strategy I would like to see. And ultimately, if we're able to do that, having neoadjuvant trials to see if we can, to some extent, replicate what has been generated in melanoma. Like what about treating patients where the tumor is still there? And does that provide an enhanced benefit compared to pembrolizumab as an adjuvant strategy? So perioperative setting is something that I'm looking for.
Absolutely.
Yeah, I was going to say something similar. I'm really excited about all this data that's starting to be generated in the largely adjuvant setting. But particularly the part that I'm enthusiastic on, just to very briefly comment on what we started off with Kim 1, I'm really excited to see us using some of these, hopefully in the future, using some of these tools to better select who needs those patients. I mean, roughly half of the patients right now with high-risk locally advanced disease are cured with surgery. So it hopefully will help enrich these future adjuvant trials a lot more. And in terms of the refractory setting, we're still largely struggling with how to deal with this disease once it's become IO refractory. And there's some really promising, very early data with various immune effector cell approaches like CAR-T compounds, et cetera, that I'm enthusiastically watching for additional results on.
I think there's a session on Saturday on immunotherapy refractory RCC, so I'm sure we'll hear about some of those trials to come. And we didn't really touch yet on non-clear cell. Is there anything that you're excited about when it comes to non-clear cell? I know we've had some data in the last year, and there's an abstract or 2 on Saturday as well.
Yeah, so before we jump to that, just because I'm from City Hope, and I'm going to be very biased with my answer. So for the future, maybe not for this meeting, but I'm looking forward to the microbiome-based interventions. I think it's one of those things that in the global perspective are cost-effective. They're going to have shown like very low toxicity. So I'm very aware that the information we have right now comes from very early phase 1 trials with 30 to 50 patients, but after what we learned from the Tawagi trial presented in ESMO, I think that's also a very interesting way to approach these patients that I think could be replicated in a world scale without, increasing the toxicity. But, early data, but I'm very excited about that. And now jumping back to non-clear cell, I think it's a field that's evolving. Nevertheless, it's like such heterogeneous at the end of the day. Important efforts have been made, for example, with a sunny forecast that was presented in ESMO that did show in comparison to TKI, either cabozantinib or whichever the physician decided to use, some important activity with a combination of nivolumab and ipilimumab. Nevertheless, I'm hoping for stronger data at the end of the day, the endpoint that it shown like an improvement in the 12-month overall survival, but I want to say I'm carefully optimistic on how that field is evolving. And we have also very nice data with TKI combinations, with TKI-IO combinations with Len-Pembro and also with Nivo-Cabo. So I think we're moving forward we still need to be better. So probably the PubMed trial is going to be the one PubMed 2 trial is going to be the one that is going to end up answering a lot of these questions that we have still lingering.
Well, I hope so. but I
You know.
but I will say that it has been really exciting for me to see over the past couple of years that we really have embraced research in non-clear cell disease, right? So shortly before my time, of being an oncologist is when we had these complete basket trials like ASPEN and ESPN that just included all cancers, all non-clear cell cancers, and reported on the data in aggregate. And now we're starting to get very specific disease histology trials. They may still enroll patients, with all non-clear cell, but at least they're reporting the data very specifically, like the Keynote trial with pembrolizumab monotherapy, or Keynote B61, which included a variety of histologies, but it really operated more as like an umbrella trial, and each of the disease-specific results were reported. Or at this meeting, we have, an abstract being presented on FH deficient disease.
Right.
So it's really exciting because that's how we're going to move the needle of progress for these patients that desperately deserve it, instead of just assuming that what works for clear cell is going to work for chromophobe and for RMC and papillary.
Absolutely.
Right?
Well, I like the plug on papillary cancer to finish out.